evening, everyone, and welcome to our final session of the Renew Education series. This evening, we're joined by Sarah Muir, one of our genetic counselors at the cancer program. And tonight's topic is hereditary cancer and your family tree. So as always, we just ask you to stay muted during the presentation, but if you have questions towards the end and you're comfortable speaking on camera, you can unmute yourself, or you can use the chat or the Q&A function. If you want to throw questions in the chat as we go along, and then we can get to those towards the end. But if you have questions as we're going along, you can go ahead and throw those in the chat. We are recording this, and I will send this as well as a copy of the slides following the presentation, probably early next week. And if you have any other, just letting somebody else in, if you have any other questions for me afterwards, you can use the email that I've been communicating with in the last couple of weeks, or if you've missed a presentation, go ahead and let me know and I can forward that on to you. But I think we're all set to go. So Sarah, go ahead and take it away.
All right, good evening, everybody. And as Shannon said, thank you all for coming tonight. Today we'll be talking about hereditary cancer and your family tree, and I'm hoping you'll be able to take away some good information from this session. And I'm always welcome to questions. As Shannon said, I will mostly be addressing the questions at the end just to make sure we cover all the topics, and some of the questions may get answered anyway through the presentation. So feel free to write down your questions in the chat, Q&A, or at the end you can unmute and we can have a conversation. All right, and as Shannon mentioned, I am a genetic counselor here with the Windsor Regional Cancer Program, and we do service Chatham, Sarnia, Windsor area, and the surrounding counties. All right, so through the presentation today, there's really four main things I'm hoping to do with this talk. One is to just give a general overview about genetics and cancer, how those two things can be related sometimes. I'll also highlight family history that might make it high risk for a genetic or hereditary condition, and give you tools to collect and understand your family history, looking for those red flags that might be indicators of something more might be needed or indicated for your family. And we'll talk about when to seek out genetic counseling and or genetic testing based on your personal and family history. And just a few disclaimers here. So this is intended to be an informative session about when to seek additional consultation with a genetics professional or with your healthcare providers. And no means is this direct advice or guidance on what you should be doing in your personal situation. It's not intended to replace that clinical consultation, but rather just give you information and tools to be able to speak with your own healthcare providers about genetics and hereditary risk. At the end of the day, if you do think you might be eligible for any of the things we talk about today, like increased screening or genetic testing, please ask your doctor about it. All right, so to begin with genetics. We all know a little bit of something about genetics, whether we remember taking high school classes about genetics or university courses, or even just knowing those simple concepts that we all know about. We know we get genetics from our parents. We tend to look like our parents, or often babies are told they look like their fathers, and that's where it comes down to is genetics. So to start from some of the ground rules or the basics to make sure we're all on the same page to talk about these concepts. To start, we all know or might remember from high school that the human body is made up of millions of cells. Inside cells are structures called chromosomes, and chromosomes contain all of your DNA, or your genetic material. And pieces of your DNA or portions of DNA make up genes. And genes can really be thought of as the instructions for how your body grows and develops. So that's eye color, hair color, shape and function of your heart. Those are all features determined by your genetics, by your genes. And it's thought that we have actually over 23,000 genes, each doing a separate role or job in the body. And typically, we have 2 copies of each gene. So if we pretend we're this gentleman here who has a light blue gene and a dark green gene, He got one of these from each of his parents. So his father passed on the green copy and his mother passed on the blue copy. And the colors are just to show that inheritance. And when somebody has children of their own, they pass on one of their 2 copies. And this is how family traits get passed down through the family, like having blue eyes, freckles, a big nose. These features can be passed down through our genes and our genetics. So now we know a little bit about genetics and genes. How does that relate to cancer? And the truth is cancer really at its root and cause is DNA damage. So damage to our genes. And damage is something to our genes that happens over time. It can be due to the environment, the natural process of aging, lifestyle choices like smoking or consuming alcohol, and even other treatments like radiation, whether that is from a cancer treatment radiation or just thinking of UV damage from the sun. All of these factors play a role into DNA damage, and it is a normal process of being a human is dealing with this DNA damage as we age. So we can see here in this diagram, we have what a typical gene might look like or is depicted. And a typical gene, like we mentioned before, can be thought of as the instruction to do a job. A gene gets turned into a protein. Protein can be thought of as the little worker carrying out that job. And in this case, the job of this protein or this worker is to make sure the cells in the body are controlled and growing healthy. They're nice and organized and they're doing what they should be. The problem is with DNA damage is we have a spelling mistake in these instructions. So that means the worker can no longer read that instruction anymore to carry out its job. So that protein doesn't work. The worker doesn't have a job to do anymore. And that's when we see the cells that were normally controlled by having a healthy gene are no longer controlled. So we see uncontrolled cell growth and division, which ultimately leads to tumor and cancer formation. So to break it down, thinking about cancer and genetics, about majority, 75 to 85% of cancer is considered sporadic cancer, meaning cancer that just happens by chance, maybe due to a combination of risk factors like the environment, lifestyle, natural aging, those aspects that I mentioned that are just part of being human. Some of them under our control, like lifestyle choices, and some of them aren't, like the environment and the aging process. About 10 to 15% of the time with cancer, we see what's known as familial cancer risk. This is where we might see cancer more than we expect by chance alone in the family, but we don't find anything with genetic testing or when we look at the genes. And this could be due to that, you know what, often family members share same environments growing up. So maybe there's a common risk factor there. And the smallest portion of the time with cancer, about 5 to 10%, is when we see this hereditary cancer risk. That's where we do find a genetic change or spelling mistake in the gene being passed down through the generations, which is causing an increased risk for cancer, or otherwise known as a predisposition for cancer. So the question comes down to, who do we know who falls into this 5 to 10% category? And that's where it comes down to your family history. Family history is very important when we think about genetics, because that's how we see patterns or red flags that could make us suspicious. Maybe there is something genetic or hereditary going on. So with your family members, we're talking your brothers, your sisters, your mother, your father, children, even further related relatives like aunts, uncles, and cousins. They can all have an impact on your risk for cancer based on their own histories, and they can give us clues. So family history is important because, as we've touched on a little already, it determines what cancers are most likely to occur. If there's a strong family history of breast cancer, for example, you may be at an increased risk for breast cancer yourself compared to somebody who doesn't have a family history of breast cancer. And knowing that family history can help guide screening going forward if you should be doing more breast screening, for example, if you have that strong family history. So it impacts screening, but can also impact eligibility for genetic testing. In Ontario, genetic testing is funded for certain people based on meeting eligibility criteria, which often has to do with having a family history of cancer. And it is specific types or criteria that does need to be met to be covered by OPE. And this is based on those who are thought to have an increased chance of having a genetic change or hereditary predisposition for cancer. So now I'll spend some time going over the different features of hereditary cancer in families, when we're suspicious, when we're less suspicious. So there's really 5 main categories that we look at looking at a family history, or 5 main aspects. One of them is age. So unfortunately, part of being human is as we get older, our chances of developing a cancer also increase. That's why we tend to see cancer diagnosed in later ages, often beyond age 50. If cancer is diagnosed at an uncommon age, like in 30s, that's very uncommon for a 30-year-old to have cancer. And this can depend on the type, but just in general. So that could make us more suspicious that maybe there's something underlying going on here. We also look at what cancer types are in the family. Certain cancer types can be more suspicious of having a genetic hereditary factor versus others can just more commonly be due to environment. We also look to see, are there people in the family who had more than one primary cancer? And by primary cancer, we mean a new cancer. If cancer has spread to another location, for example, that's still counted as one cancer diagnosis versus having 2 separate cancers. And if somebody's had more than one primary cancer, again, more suspicious that maybe there's a reason, an underlying reason for that. We also look to see in the family history, is it just one generation affected, or are there multiple generations affected? Are you affected along with your mother, along with your mother's sister and your mother's brother? Is it passing through the generations? We also look to see at somebody's ancestry or their background, because we do know people with different backgrounds or coming from different populations might have different chances of having certain genetic changes or mutations compared to other groups. So this is an example of what sporadic cancers look like. So just to orientate everybody to what we're looking at here, this is a family tree or a pedigree. So if we are this person right here, each shape represents a person. Squares typically represent males and circles typically represent females. So in this situation, this square is a man, and this kind of upside down U shape is connecting siblings. So he has 2 sisters. And the vertical line going upward is connecting his parents. So his mother and his father. So that straight line connecting 2 symbols is a relationship line. To kind of orientate, if again, he has 2 sisters, if we go up, he has a mother and a father. And then on his mother's side of the family, we see that his mother had 2 sisters and a brother. And one of those sisters, shaded in circle, had breast cancer. And shading in of these shapes is usually how we denote a condition or a cancer. And we see that she had breast cancer at 62. So this is what we might see with a typical sporadic cancer in the family. There's only one cancer in the family, nobody else has had cancer, and the cancer is diagnosed at a later year, beyond 50, more typical of this sporadic or common risk factors rather than being hereditary. So overall, this one, we would see it and say, it doesn't look very suspicious for a hereditary risk in this family. This is what might look like familial cancer risk. So in this scenario, we have a woman here who's had colon cancer at age 60. And on her mother's side of the family, she has an aunt who also had colon cancer at age 85. So in this scenario, we see colon cancer for 2 people in this family. So perhaps a little bit more than we'd expect just by pure chance. But again, these cancers tend to be diagnosed later ages, and it is only 2 people in the family. So it could just be by chance still. So this is where it looks like there could be maybe a little something going on here, but perhaps not genetic, maybe rather another common risk factor in the family, or something we just can't pick up with our genetics that we know about today. Now, this is an example of when we see hereditary cancer risk in a family. So automatically, you might be seeing a lot of these shapes are filled in. And that is what we tend to see is a significant amount of people having cancer in the family and the same types of cancer. So to walk us through here, I hope you can see my mouse, but on the far left side on the bottom, there's that circle shaded in that says OV42. So that stands for ovarian cancer at age 42. So this person, through her father's side of the family, she has an aunt who had breast cancer at 29. It's quite young for a breast cancer, so that's already a red flag. Another aunt who's had both breast and ovarian cancer in her 30s. Again, a couple red flags there, those young ages, as well as two primary cancers. And that aunt also had two children, one with breast and one with ovarian cancer. And then we even have a third aunt with ovarian cancer at 49. And this person also has another cousin with breast cancer at 63. So this family history is more significant. We see those young ages, we see multiple cancers, multiple generations affected, and we tend to see breast and ovarian cancer go together as well when we think about genetic hereditary risk. So this family certainly is suspicious for an underlying genetic condition, and certain people in this family, particularly those who had that personal cancer history, would likely be eligible for increased screening and genetic testing. Now, sometimes it's important to recognize that it may feel like everyone in my family has cancer, but it's important to look at exactly who are we talking about. So this arrow is pointing to a 32-year-old woman here. So we'll pretend we're that person with respect to the rest of the family. So through her father's side of the family, she has an uncle who had lung cancer at 62. So certain types of cancers, as I mentioned earlier, are more suspicious for genetic hereditary factors compared to others. Lung cancer is one of the cancers that typically is not thought to have a strong hereditary or genetic factor. Usually smoking is caused due to our environment or lifestyle choices like smoking or just exposure to smoke and chemicals around us. So with that lung cancer, we're not suspicious of risk for our patient, this 32-year-old. Now looking at her other uncle, there's another aunt who had breast cancer at 68. So while it is an aunt of hers, it's not an aunt by blood. So that's a good pointing out, is to recognize when we think of genetic risk, it really is talking about blood relatives. So step relatives or people married into the family or partnered into the family, they don't affect your own cancer risk because you don't share the same genetics with them. So that aunt doesn't affect the risk for this person. Now, if we go up a generation, her grandfather had prostate cancer at 81. Again, older age here, and it's the only prostate cancer in the family, so it doesn't look suspicious. It looks more like sporadic types of cancer. And again, a grandmother's lung cancer at 80, older age, most likely due to other risk factors besides genetics. And then again, this grandmother, her sister had breast cancer at 89 and has passed away. And I should note those slashing symbols through the different shapes. That's just to denote that somebody has passed away. So with that breast cancer at 69, again, later age. And that relative is actually quite a few relatives removed from our patient, right? That's a great aunt. So the further somebody is related from you, the less of an impact they have on your risk. And it's also a good idea to note that for you to recognize and also for your doctors to recognize is that family histories can change over time. So in this scenario here, a woman, her mother passed away with breast cancer at 50. Again, one breast cancer at 50 or older, not overly suspicious for that hereditary factor. But just 2 years later, it could change into her sisters now had a diagnosis of ovarian cancer. Her brothers now had a breast cancer at 42. Both of those types of cancers are suspicious for hereditary risk as they are uncommon or less common than other types, especially the male breast cancer, for example. So now certainly it's starting to look more like that hereditary genetic risk rather than just that sporadic type. So that's why I encourage you to continue checking in with your family over time about health history and updating your doctors as well. Now, I'd like to review a few hereditary cancer conditions. Some of you might be familiar with, and some of them are less commonly known about, but just to give you an idea of different conditions that are out there, and this is by no means comprehensive of all the hereditary cancer conditions, but just to give you a few of the more common ones, or you might see come up in media. One of them is with, I'm just going to increase the screen size here. There we go. Hereditary breast and ovarian cancer syndrome, or HBOC. There are two main genes associated with this condition, BRCA1 and BRCA2, also known as BRCA1 and BRCA2. So these two genes are the most common genes we tend to hear about in the media or people know about. They're tied to the Angelina Jolie story, for example. And these are two genes that cause an increased risk for the breast and ovarian cancer syndrome. There can be other genes as well. So just to review here, with BRCA1 and BRCA2, with women, we tend to see a risk for breast cancer that's thought to be over a 60% lifetime risk. With males, we do see also an increased risk for breast cancer. With BRCA1, it's thought to be about 1%, BRCA2 about 2 to 7%. With cancer of the pancreas, BRCA1, the risk is thought to be about 5% or less. BRCA2 is thought to be about 5 to 10%. And again, these are lifetime's risk, estimating the chances somebody would develop one of these cancers by the time they're 80 if they have this mutation. For ovarian cancer with BRCA1, we can see that risk be about 40 to 60%, and BRCA2 about 13 to 30%. With prostate cancer for men, for BRCA1, we can see about a 7 to 26% lifetime risk, and up to about a 60% chance with BRCA2. Now, it's important to note these numbers that I'm sharing with you, they are accurate, but if you are doing your own research, you may come across slightly different numbers. This is because these risk numbers are just based on different research studies and estimate the risk for, in general, people with a BRCA1 mutation. They aren't necessarily specific to every person. And having a BRCA1 or BRCA2 mutation or having HBOC syndrome, it's thought to affect about 1 in 400 people. So truly, if we think of the size of Windsor, even for example, that's still quite a few people that likely have a BRCA1 or BRCA2 mutation. And when we get concerned about hereditary breast, ovarian, and prostate cancer, again, these three cancers tend to go together, as we just saw with BRCA1 and BRCA2. These are really what we're looking for. When it comes to age, we're looking, was there a breast cancer diagnosed at a younger age, such as 45 or younger? Specific types of cancers, such as epithelial ovarian cancer, metastatic prostate cancer, which means prostate cancer that's spread beyond the prostate, pancreatic cancer, male breast cancer, and triple negative type of breast cancer that's diagnosed less than 60 years old. These are all indicators that there might be a BRCA1 or BRCA2 mutation. We also look to see, is there somebody in the family or who's had breast cancer twice, again, two primaries, with one of those being less than age 50. We also look to see, are people of Ashkenazi Jewish background? Because people who have Ashkenazi Jewish background, it's thought that their chances of having a BRCA1 or BRCA2 mutation is about 1 in 40, which is significantly more common than the general population of what we would say of 1 in 400. So that's where sometimes genetic or ancestry background can have a play in risk for hereditary cancer conditions, and really other genetic conditions as well. And also just touching on, we're looking at multiple relatives being affected with mainly these three types of cancers. All right. Lynch syndrome. This is a second hereditary cancer condition. It used to be known as hereditary non-polyposis colorectal cancer, or HNPCC syndrome. And Lynch syndrome is actually the most common cause of hereditary colorectal cancer. And the two main cancer risks we see with Lynch syndrome is an increased risk for colorectal cancer, as well as endometrial cancer or uterine cancer. There are 5 genes, which are known as the mismatch repair genes, that are associated with this Lynch syndrome. And Lynch syndrome is thought to affect just under 1 in 300 people. So even more common than having a BRCA1 or BRCA2 variant or mutation. And it's even thought about 2 to 3% of all colorectal cancers might be due to Lynch syndrome. And given that Lynch syndrome is more common and might be underdiagnosed in the population, there are certain aspects we look for. So again, with age, we're looking, is there a Lynch syndrome cancer less than 50? Are there Lynch syndrome cancers in multiple family members? And again, with Lynch syndrome, we do see an increased risk for cancers of colon and endometrial, but also several others that were listed on the last slide. And you can see on this slide here, generally these other cancers affect the GI system. We also look to see, is there somebody who's had 2 Lynch syndrome cancers, and both of these being less than 60? Is there one person with a Lynch syndrome cancer and 2 other relatives also with a Lynch syndrome cancer? And certainly age takes into account with these. For example, is there somebody who's had a colon cancer and their mother and their mother's sister all had colon cancer? That gets a little more suspicious. And with ancestry, there are certain backgrounds that have increased chances to have certain genetic changes related to Lynch syndrome, but overall ancestry background doesn't play as big a role with Lynch syndrome, and that all ancestries are at risk to possibly have a Lynch syndrome mutation. No ancestry is specifically higher risk than others to what we know today. Now, as I mentioned with Lynch syndrome, because it is thought to be fairly common, about 1 in 300 people and likely underdiagnosed, there's a new testing that's been introduced in the last couple of years in Ontario. It's called universal screening for Lynch syndrome. So what this is it's a reflex test that's done on newly diagnosed Lynch syndrome related cancers. So what that means is if somebody's diagnosed with a Lynch syndrome cancer, like colon or uterine cancer, and surgery is done to remove that tumor, this testing is usually automatically performed on that tumor as a part of regularly pathology and characterizing that tumor to know how to best treat it. So typically with Lynch syndrome, we expect to see, or I should say just in general, not with Lynch syndrome, we expect to see certain markers on a tumor. We expect to see these, and if they're there when we do this universal screening, likely that colon cancer, for example, is not related to Lynch syndrome, could be due to other common risk factors or just by chance bad luck. But we can't rule out other conditions as well. But at least for Lynch syndrome, we're a little reassured here. However, if one of these markers that we're expecting to see is now missing, this could be due to an underlying mutation in one of these Lynch syndrome genes. And that's when further testing might be needed. It might be further testing on the tumor itself or genetic testing on the person to see were they born with Lynch syndrome. Before we go on, I just want to say the next few slides, there are going to be some photos of the inside of a colon. So if people don't want to view the inside of a colon looks like with some polyps, that's okay. Just avoid the screen for the next couple of slides and I'll let you know when we're finished looking at the photo slides. All right, so hereditary polyposis. This is another hereditary cancer predisposition syndrome. So classic familial adenomatous polyposis, which is a mouthful. So for short, we call it FAP. So with FAP, it's a genetic condition where we see over 100 adenomas, which are a specific type of colon polyp. And it could be hundreds to even thousands of colon polyps. And the image to your right is a picture of the colon taken during colonoscopy. And these are what polyps look like, or what they can look like, just growths in the colon. And you can see in the top right there in the graphical picture, the colon, where typically you expect it to be smooth, it looks very rough or textured in this image, representing all these colon polyps. With FAP, the average age of onset of when we start to see symptoms or colon polyps is around 16 years old. So it's quite young, but we have seen it to be detected in people even from 8 to 24 years old as well. And unfortunately with this condition, if somebody does not have treatment, it's a nearly 100% chance or a guarantee that they will develop a colorectal cancer in their lifetime. And that's just due to the numerous colon polyps that are developed. Eventually, one of these may turn into a cancer if untreated. There can also be other cancers or tumors related to FAP and also non-tumor findings. And what's interesting with FAP is sometimes there is no family history. So with Lynch syndrome, BRCA1 and BRCA2 mutations, generally these are inherited from a parent, could be passed on to children. With FAP, about a third of the time when it's diagnosed, it could be due to what's known as a de novo mutation, which means a third of the time, that mutation occurred for the first time in this person. They didn't inherit it from a mother or from a father. It happened brand new in them when they were an embryo or very early in development. That's when the mutation happened. So now they have this condition, but there's no family history. So it can sometimes appear like it's coming out of the blue for somebody. But if they are found to have this condition and a mutation, it can still be passed to children. Starts with that person, but can affect next generations. Now, there is an attenuated FAP version, which is a milder version in a way, is where we see maybe up to 100 colon polyps, but it even could just be a few or a dozen or so. And we typically do expect to see colorectal cancer in the family, usually older onset. And other non-gastrointestinal, non-GI cancers are less common with this attenuated version. What's interesting about these two different conditions, they're actually caused by the same gene. So the gene is known as APC, that's just the name of the gene. And depending on the specific type of mutation or the specific type of spelling mistake in this gene, changes the outcome of which genetic condition, the classic form or the attenuated form that somebody might develop. Sometimes we can get it clear which one, and sometimes it's hard to know exactly what group somebody might fall into. Familial malignant melanoma. This is also another predisposition syndrome. So in general, with skin cancer, including melanoma, our greatest risk factors tend to be our skin pigmentation and our exposure to the sun. And what I mean by skin pigmentation is the skin coloring. So your skin gets its color from a pigment called melanin, and special cells in the skin make melanin. If your body makes more melanin, your skin gets darker, versus if you have less melanin, you have lighter toned skin. And having more melanin, so a darker toned skin, naturally protective from the sun's UV damage. So generally, when we see people with darker skin tones, they have a lesser risk for developing skin cancers compared to somebody who might be paler or lighter pigmented skin. But even though we see that trend, certainly people who are of darker skin color are still at risk for developing skin cancer. We can never say that chance is 0%, unfortunately. That being said, while the most common factors are our skin pigmentation and the sun exposure, there can be hereditary factors leading to melanoma, specifically a type of skin cancer. So when we see more than 3 melanomas in the same person, or when we see melanoma at a younger age, such as 40 or younger, and a personal or family history of pancreatic cancer, we can get more suspicious. Maybe there's a hereditary genetic factor going on here. And there are 3 main genes associated with hereditary forms of melanoma: CDKN2A, BRCA2 that we talked about earlier, as well as CDK4. And on the left here, I just give you a little map of the incidence or the rates of melanoma in the population. So we can see for us here in Canada and lower in the United States, this dark red indicating there are a greater amount of skin cancers that we see versus the lighter colors like a light yellow over in Africa, we see less of that. And again, it actually has to do with some skin pigmentation for these populations, but also our ability to gather data and exposure to the sun. Now, certainly we reviewed quite a few hereditary cancer conditions today, but there are others. Those are the more common ones. There are rare ones, and there are certain cancers out there that if it's a specific type of cancer, it's very suggestive there could be a hereditary factor going on here. So for example, thyroid cancer in general, typically not thought to be something that has a strong hereditary factor, but specifically medullary thyroid cancer, that is associated with a condition called multiple endocrine neoplasia. So whenever somebody has a medullary type of thyroid cancer, automatically that's a red flag, and that person might be eligible for a genetics assessment to see if there's anything further needed. And these stars are just highlighting some of those other key cancers that might be an indicator for a hereditary cancer predisposition. But again, keeping in mind overall, we focused on genetics today, but the vast majority of cancers are not caused by hereditary predispositions. All right, so in case it hasn't been made obvious through the last 30 minutes or so, hereditary cancer, it's complicated, right? On the left-hand side here, breast cancer, it can be associated with many different genes or mutations in many different genes. On the other hand of things, one gene listed here as TP53 can be associated with many different types of cancers. So there's a lot of overlapping information and it can get complicated. And that's where genetic counseling comes into play. So in Ontario, genetic counseling is a service for those who are found eligible based on personal or family history of cancers that might need a genetics assessment to go over their family history or personal history and talk about hereditary cancer risk, see if there's any additional screening that might be warranted for you or the family, as well as to see if genetic testing is something that's eligible for. In the end, as through a genetic counseling session, the goal is to have that conversation, discuss personal and family history, and give you information to empower what do you want to do. If you are eligible for these programs, is that something you want to do or not? Ultimately, it's in the hands of the patient. What genetic testing is it's a blood draw. Typically, it's how the test is done. And looking at these genes, we essentially scan along these genes with a magnifying glass, almost like a spell checker, looking to see are there any mutations or spelling mistakes causing this increased risk for cancer. Again, usually done by a blood draw for people who meet specific eligibility criteria for testing, and that's based off of who's thought to have a greater chance or higher risk to have a mutation. And if you do meet this criteria, it is fully covered by OHIP. There's no out-of-pocket cost. So with genetic testing, there are really 3 different types of results we could get back. One of them is considered a positive result. So positive result means we did find that spelling mistake or a mutation is found. And this can be helpful information for the person themselves and family members. So for the person, it can help guide, sometimes it can help guide treatment, what might be the best options for specific chemos, for example. But it also might just be used for future screening or preventative screening. Say somebody's found to have an increased risk for breast cancer. Well, instead of starting routine mammogram screening at age 50 every 2 years, which is currently recommended for average risk women, maybe this person would now be eligible for yearly mammograms and breast MRIs starting at age 30, right? So it can help to be preventative. Or sometimes there's preventative options as well, like somebody who has an increased risk for breast cancer might choose to remove both breasts to reduce that risk of cancer in the future. And the goal with genetic testing really is if we know there's this increased risk, let's do screening at younger ages or with better technology so that if there's going to be a cancer, we try and catch it as early as possible. Or we can even talk about risk reducing options like preventative surgeries. And that's how it can be impactful for a person directly, but also their family members. Because as we know, we share our genetics with family. If one person is found to have a mutation, their family members could also have it. So they would then be eligible for genetic testing too, to know do they have those same cancer risks and could be doing more for their health. We could also get a negative result back from genetic testing. That means we looked at all the genes that we were looking at and we didn't find anything, no spelling mistakes or no mutation was found. Now, in one way, this is often seen as reassuring information. We looked at your genetics, didn't find anything saying there's an increased risk or a predisposition. On the other hand, we can never say the risk for cancer is 0, or there still may even be an increased risk for cancer because that family history that's might be unexplained by this test. So generally with a negative result, any recommendations for screening or preventative measures is really based on someone's personal and family history rather than the outcome of the test. Also for other family members, typically they're not going to be offered genetic testing because nothing was found. So there's nothing to test the other relatives for. But other relatives may still be eligible for their own genetic testing, especially if they've had a cancer themselves and we're still suspicious of the family history. There's a third type of result, sort of in between a positive and a negative. It's what we call a variant of uncertain significance, or a VUS. So this means we did find a variant or a genetic change in one of the genes, but we just don't have enough information yet to know, does this gene truly cause an increased risk for breast cancer, or is it a completely normal, harmless thing to have? And we get these types of results. They're not very, they're not uncommon, I should say. About 30% of the time with genetic testing, we get these types of results. And that's because we all have some genetic changes. That's what makes every person unique. It's just whether or not a genetic change causes any health issues or not. With the BUS, typically they are treated like a normal or negative result, meaning we don't make any recommendations based on these, because most of the time they do turn out to be a completely normal, harmless thing in the future. So in the case of these, just like with a negative result, any recommendations or screening is going to be based on the personal and family history of cancer rather than this genetic test. And instead, we just encourage a person to keep in contact with their genetics team every couple of years to see if there is updated information about it. And similar with a negative result, for family members, they're not going to be offered testing based on this result because, again, we don't know what this result means. Usually it is harmless or nothing, so we don't test other relatives. Now, to start with genetic testing, who do we test in a family? So we often see this when we get referrals to the genetics program, is somebody comes to us saying, you know what, I have this family history of cancer, I don't have a cancer. In these situations, if possible, we always want to start with genetic testing for a family in the persons who's had cancer. So in this example here, the person seeking counseling is unaffected. Her father's had a colon cancer at 45. And on her father's side of the family, she has an aunt who had uterine cancer at 38 and has passed at 45, and a grandmother with colon cancer at 42. Now, some of you might be thinking, this looks like Lynch syndrome. And you're right, it is suspicious for Lynch syndrome. If you recall, with Lynch syndrome, we have an increased risk mainly for colon and endometrial or uterine cancer. We see both of these with this family, and we see them 3 relatives, multiple generations, and in fact, all 3 of these have been diagnosed less than 50. So this is suspicious for Lynch syndrome. But with genetic testing, the best person to have that test is the person seeking counseling, their father, who has that personal history of colon cancer. And this is because if there's going to be a mutation in the family causing an increased risk, well, we're most likely to find that in the person who's had the cancer we're suspicious about. And if we find a mutation in the family in that person, then now for his daughter, the person who originally came to us, we know exactly what to test them for, and we can get a much clearer answer of what is their risk for cancer. Do you have that mutation or not? Versus if we start testing with the father who had the colon cancer and we didn't find any mutations, he had a negative result, well then there's no testing needed for his children because we didn't find anything with him, and you can't pass on what you don't have. That being said, this person still has that family history of colon cancer, so they're likely going to have colonoscopies at younger ages or more often than most people because that family history still exists and we can't explain why. Versus if we started genetic testing with the person with no cancer history and we get a negative result, meaning we don't find anything, it really is more uninformative. We don't have as much information as we would like. We don't know, does the family have Lynch syndrome and this person truly doesn't? Or would we not have Lynch syndrome in this family and there's still that risk? There's just more unanswered questions. So it's less helpful for this person to define really what does their risk look like. There's more unanswered questions. Okay. Now, there are certainly challenges and limitations when we think of hereditary cancer and genetic testing. So genetics is constantly evolving. We have some well-known genes like BRCA1 and BRCA2, but we also have genes that we've learned about much more recently, and we're still starting to gather information about them. So we might not know all the genes related to breast cancer, or we might know, okay, this gene does seem related to breast cancer, but we don't really know how much risk yet. We're still learning about it. It's also important to recognize that understanding genetics can be tricky for both people themselves who have a mutation, as well as their healthcare providers. Results like that variant of uncertain significance, it can be tricky sometimes to wrap your head around, they found something, but we're not doing anything with it, or there's no reason to do anything with it. So sometimes that information can be hard, both for patients and for their providers. It's also important to note that knowing there's possibly an increased risk for cancer in someone's future, it can have mental health impacts. That might not be information that everybody wants, and that's okay. Something like genetic testing is a very personal decision and is up to each person. One thing just to be aware of as well is some people can be worried about genetic discrimination. Am I going to be denied life insurance because I have a BRCA1 mutation, for example? And that really did used to be a serious concern. Thankfully, in 2017, there was a law in Canada that was put into place called the Genetic Non-Discrimination Act, which makes it a criminal offense for third parties like a life insurance company or employers to really ask about genetic testing results and use it against you. So the extra protection in place really made it easier for people to have this testing without that worry of this discrimination from employers or insurance companies, for example. So at the end of the day, it really comes down to those people who are eligible for testing and it's indicated or an option. What do you think? Do the benefits of potentially being proactive for you and your family outweigh the possible limitations or risks of the mental health of knowing there's this increased risk? Or some people may feel blame if this is found in the family, even though there's nothing we can do whether to control what we did or did not pass on. So ultimately, it is a very personal decision. And your family tree is unique to everybody as well. So we talked about a lot of generalizations to this presentation, but keep in mind every family is unique, different ages, different amount of people in the family, all those factors can come together when we think about a risk assessment for your family. So I challenge you now with some homework. So we'll provide these resources after the presentation. It's just a list of keeping track of your family history. Now this one's designed for family cancer history, but this can even be used for other health conditions in the family, blood pressure, heart attacks, all those things your doctors might ask you about the family history, and you don't know until you ask often. So I challenge you to complete this exercise and just keep tabs really on your family history information because it impacts you and your loved ones. So when collecting your family history, we want to be asking three main things: who, when, and what. And it's certainly okay to not know all these details, or some family members might not be open and share information like this, but collecting what you can is always helpful. And those are the three main things we want to collect. So for who had cancer in your family? And what is the degree of relationship? Are they closely related to you, like a first degree relative? So that would be your parents, brothers, sisters, your children. Are they a second degree relative, like grandparents, aunts, uncles, half siblings, nieces, nephews? Or are they even further removed, which is considered third degree relatives, like cousins, great grandparents? And again, the further somebody is related to you, the less of an impact they have on your risk. And what is their primary diagnosis? Or in other words, where did the cancer start? We often might hear they had cancer and it had spread to many places: the lungs, the liver, kidneys, which is unfortunately unfortunate. But for genetics wise and thinking of hereditary cancer risk, it's most helpful to know, where did the cancer start? What was the primary? And if somebody had more than one cancer, was it a second new cancer, a new primary? Or had the cancer just come back, or did it spread to somewhere else? Because again, that would count as one cancer diagnosis. And sometimes if you are seen by genetics services, they may ask for consent forms or release of information to request records from family members to confirm that diagnosis. To be able to say exactly what type of cancer was it. We also want to know when, the age that somebody was first diagnosed with their primary cancer. So what is next? So if you think you are eligible for genetic counseling based on the information provided today, talk to your doctor about a referral. If your physician doesn't yet have a referral form for us, which many do in the area, they can always give us a call and request a referral form, and we're always happy to send out that referral forms and take a look. So just to give you an idea of what our process here looks at the Windsor Regional Cancer Genetics Program. And again, we provide services for Chatham, Sarnia, and all the neighboring communities. And this can be a different model depending if you are seen at somebody somewhere else in Ontario or even other provinces or countries. But for us, typically, a referral is made to us at the Cancer Genetics Program. One of our genetic counselors will review the information, the history that's provided, and sometimes we might send a family history questionnaire to the patient to collect all that family history information to help us know what's going on and see, is this person going to be eligible for a high risk program or high risk screening or genetic testing? And if somebody's found eligible, they'll be accepted into the program. They'll have a genetic counseling appointment and assessment. If they are not offered testing because they don't meet criteria or aren't the best person in the family to have the testing, often it's still discussed about what screening recommendations should be done based on that personal and family history. If somebody is offered genetic testing, again, we talked about those 3 different types of results: mutation found, positive; no mutation found, a negative; and the variant of uncertain significance, or VUS, that uncertain result. And based on those results, again, we would go over recommendations for you going forward, referrals to specialists as needed, and help provide you with resources for support, whether you want to get connected with the genetics community or just support to share this information with relatives. All right, and with that, I'm happy to open it up if anybody has any questions. I did see a couple pop up in the chat, so I'll try and get to those first, or if anybody wants to unmute, feel free as well. Okay, so I see a first question here, so I'll read it aloud for the group. Good evening. For example, if the father got lung cancer because of lots of smoking, that kind of cancer can be transferred to the kids. So that to me sounds like sporadic cancer risk. If the father had lung cancer and he was a heavy smoker, especially if it was later in life when he was diagnosed, that seems sporadic. I wouldn't be overly concerned about there being genetic hereditary factors passed on to the kids. That being said, everybody's at risk for cancer. Everybody's at risk for lung cancer. So we can never say it's a 0% chance. I just, from a hereditary genetics frame or lens, doesn't look suspicious to me. If that father has kids and his kids smoke, well, unfortunately, they might be increasing their chances of lung cancer too. Or if the father smoked in the house and there's that secondhand smoke exposure, again, all these risk factors can contribute to cancer risk. Some of them are under control and some are less. We're reading the first question. Second question here, I'll also read it out in a moment. Okay, so someone's mentioning that in an example where they didn't have children, should they consider genetic testing for better information for the rest of the family? So yes, it still can be helpful information for family members. It could be helpful information for you in your future, but also your other relatives, not only children, but your siblings, your parents, or even further relatives like aunts, uncles, cousins. If you're found to have a mutation, these relatives would be eligible for genetic testing as well, because they also have a chance to have that mutation. And the follow-up question to that was, what is the cost if you don't meet criteria? So with Ontario and our genetics programs, because we are funded through the Ministry of Health, our goal is to provide services for those who are considered have a higher risk of having a genetic mutation. So we facilitate testing in those scenarios. If somebody does not meet criteria for genetic testing through OHIP, typically we don't facilitate that testing. There are options out there that people can explore on their own, like self-pay testing or getting involved with research studies. But typically that's something we wouldn't help facilitate, but you can always look in onto your own, certain things to look for, make sure labs are what's known as CLIA certified, and there are physicians or genetic counselors available to help you through that process. Okay, so this is actually a very great question. So if one of the parents diagnosed with a cancer, for example, colon cancer, this cancerous cell can be transferred as another type of cancer to the kids. So we want to be very clear. Cancer itself is not transferable. If I have a colon cancer and I interact or touch somebody, I can't pass my colon cancer on. Cancer doesn't work that way. You can't pass it on to people. You can't pass it on to children that way. What we're talking about here is the hereditary cancer genetics is somebody being born with a spelling mistake or predisposition for cancer that is hereditary, meaning that risk for cancer can be passed on to future generations. The cancer itself is not passed down. It's just an increased risk for cancer that can be passed down. And to maybe address another point of this question is, if someone has a colon cancer, can a child be at risk for a different type of cancer? Yes, we can see this, right? If we think back to when I talk about BRCA1 and BRCA2, we see an increased risk for prostate cancer for men, breast cancer for women. So a father who has prostate cancer and has a BRCA1 mutation, a daughter of his is at risk of also having that BRCA1 mutation. And if they do, they could develop breast cancer. So we can see different cancers with the same gene in the family. Okay, I have another question here. Should a woman who has had her mom, grandmother, and paternal great-grandmother with breast cancer, should they get tested? So thank you for the question. Again, I don't have all the information, so I can't specifically tell you if criteria would be met. I would suggest at least talking to your doctor about it and seeing if you might be eligible based on ages, because that question will depend on how old were these relatives when they had their breast cancer. Was it in one breast? Was it in both breasts? All this information goes into play when we think about who might meet criteria for testing or increased screening. One thing to keep in mind, because this question mentioned a mom, a grandmother, and a paternal great-grandmother. Paternal great-grandmother, that relative's pretty far removed from you. So again, further removed, less impact on your risk. Also, if you have your mother and a paternal great-grandmother, which means a great-grandmother on your father's side of the family, those two breast cancers are not related to each other, right? Those people are not related by blood. So when we think about hereditary cancer risk, we have to think of your mother's side of the family and a father's side of the family as being separate. So if you have aunt with breast cancer on your mother's side, aunt with breast cancer on your father's side, that is very different from a hereditary genetic standpoint than if you had two aunts on your mother's side with breast cancer, right? So keeping that in mind, not related by blood, the risk is unrelated to each other.